Hey there everyone, it's Adam again, and today we're going to be discussing immunizations. So just a little brief history of vaccines, kind of interesting. Back as early as the 1600s, they were actually looking at inoculation with smallpox, in which, fortunately, we don't have to do this today, but they were able to transfer pus from a smallpox infected patient, put it into a non-infected patient, and all of a sudden they developed some degree of immunity or resistance to the disease. As I said, fortunately, our immunization practices have gotten a bit more advanced since then. In 1796, we were actually able to develop the smallpox vaccine. One of the things they noticed was that the milkmaids who had contact with the cowpox didn't get smallpox. And so, actually, the word vaccine comes from the Latin word vaxa, which it means cow. So you think cows for our current understanding of immunology to some degree. And then later on after that, we have Pasteur, who helps to develop the rabies vaccine, which we'll talk about a little bit later. We have things like injectable polio, and then even an oral polio vaccine introduced. So as you can see, we've had some understanding for a bit of time, but it did take quite a bit before we actually got kind of up and running and developing these vaccines for human administration. And here you can see a list of vaccines that we have for different preventable diseases. And obviously, we don't need to get vaccinated against all of these things, but certainly, based on age, based on risk factors and location, you may be more susceptible to different diseases, and they may need different vaccines. So certainly, if you're traveling outside of the country, to certain areas, you may need something like a Japanese encephalitis or a typhoid vaccine prior to going. Looking at the just kind of an example of how effective some of these vaccines can be. This is a graph basically showing the elimination of polio. So looking at polio happening, the incidence of it happening between 1980 to 2005. You can see that the blue bars are going to be the number of cases happening. And then looking at the coverage of people who are vaccinated, you can see it kind of becomes pretty steady and plateaus out right around the 1990s. And as you go forward, you have fewer and fewer instances of the disease happening. Which is good. So again, as we maintain vaccination in these patients, we keep that herd immunity going, prevent new occurrences from coming in for the most part. So why do we immunize? There's multiple reasons why people do not receive vaccines, and so some of them are well-founded, some are not so much. But certainly reasons why people may not want to have vaccines would be concerned about some of the adverse events that can occur. Certainly people will think that, if I get a vaccine, I could be that one in a million that's going to get Guillain-Barré or something like that. Some people may claim they have insufficient time or inconvenience. Certainly, as you get older, and you may, especially if you're not working in the healthcare field where you're required to get things like the annual flu shot, you may have young professionals or adults who are just saying, hey, I don't really have time to be able to go to the pharmacy or go wherever to get my shot. Some people will prefer to rely on homeopathic cures instead of vaccinations. And then some people just really want to avoid all medications in general and kind of fall into that category. Certainly there's a worry of some people have fear of needles, which is kind of nice because nowadays we do have certain intranasal administrations of different vaccines. So certainly like the flu vaccine, the flu mist is nice for people who have that fear of needles. And then kind of one of the big things that you kind of have to fight against as a healthcare professional in educating patients is this kind of low personal risk for infection that people may have this perception of. They say, well, if everyone else gets one, then I certainly don't need one because I can benefit from that herd immunity, which may be the case for the most part, but then if enough people actually believe that, then obviously it's going to become a problem. So just as an example of this, looking back at kind of the Japanese example, in 1974, Japan had a very successful pertussis vaccination program, and so roughly 80% of all Japanese children ended up getting vaccinated. During that time, only about a little under 400 cases got reported. And fortunately, there were no deaths associated with that. So once the public perception became that, well, we kind of eradicated pertussis, it's no longer needed. And then some people actually feared that the vaccine was not safe. You see that in 2 years, only about 10% of the infants were actually being vaccinated. And then 3 years later, they actually suffered a major epidemic where they had many thousands of cases of pertussis popping up. 41 related deaths came from that. And so after that point, in 1981, the government said, okay, well, we need to definitely make sure we're vaccinating against this. And then sure enough, the incidence of pertussis went down pretty significantly. I myself am actually going through this since, we're having a child, and the worry about pertussis coming back has been an issue. And so previously, someone would get their tetanus booster, it would have protection against tetanus and diphtheria or TD vaccine. But nowadays, they recommend for people having small children, especially caretakers, they get the Tdap, or the tetanus, diphtheria, and then the acellular pertussis as well, since it can be so devastating to young children. We know that vaccines can save lives. Over 40,000 adults end up dying annually from vaccine-preventable diseases. And just even looking at something like measles, 3 out of every 1,000 people will end up dying in the U.S. from that. But looking at things like the incidence of Haemophilus influenza B, introducing the conjugate vaccine in 1987, we've seen a very significant decline in the incidence of that, by 98% or so. Again, looking at pertussis, looking at rates, we actually see this rising. So even between 1990 to 96, we see that increased number of cases of pertussis. A lot of those are in kids less than 6 months old. So obviously that's going to be a big concern since their immune system is not going to be really up to snuff after being born. And so just in general, vaccines we know are super important. I'm sure this is just kind of preaching to the choir to some degree, but this is why it is so important for people to get the recommended vaccines that are available. So getting into the actual science behind why we vaccinate and how it works. We obviously know that there's 2 major kinds of immunities. There's passive and active immunity. Passive being protection that's transferred from another person or an animal as an antibody. The benefit of being able to transfer these antibodies is that it provides immediate protection. So the patient is immediately protected against whatever the antibody is kind of targeted against. The unfortunate aspect of it is going to be pretty temporary for the most part. So it may only have protection for weeks to months as the body naturally processes the antibodies out of the system. So some good examples of how passive immunity can be achieved. Certainly if you are having certain human sources, if you have transplacental administration to fetuses or breastfeeding, breast milk definitely has a large number of antibodies that can be absorbed by the feeding child. Certainly, immunoglobulin we can administer. Essentially, there is using donor serum, you're able to pool large amounts of antibodies to various different antigens, and so you can actually administer an immunoglobulin that's been sterilized to patients. We'll talk more about that towards the end of the lecture. And then you can also have things like antitoxins. Basically, this is serum that's been hyperimmunized against whatever you're kind of targeting against. And then in a lot of cases, you see things like equine sources. We talked a little bit about that when we mentioned in the tox lecture about the coral snake antibody. This is actually an antitoxin made by immunizing horses. Certainly, sheep can be used as well for other type of antibodies. So things like digoxin immune fab can be generated from sheep. The crofab or the crotalidae antivenom can be found from there as well. And then on the other hand, you have your active immunity, which is going to be protection that's produced by the person's own immune system. This is generally going to be a delayed protection since the body has to be exposed to the antigen first before the antibodies will actually be produced. And then depending on the type of exposure, the durability is going to change. So certainly for some exposures, you can have lifelong protection. So think of something like the chickenpox. You typically only get that once as a child, and then you really don't need to worry about it too much later on. And so obviously sources for this could be our vaccines, which we'll talk more about in just a minute, or natural disease is obviously going to fall in this category as well. So looking at predictors of response, so looking at the couple of different factors, so mainly ones being with the hosts themselves and then also with the actual vaccine. So looking at a vaccine, how do we determine how well the patient is going to be able to generate immunity against that disease? And so one, you have to look at the viability of the antigen. So we'll talk about different types of vaccines. Some will be basically attenuated versions or kind of weaker versions of the live source of the bacteria or the virus, and then some of them will actually be inactivated. Some of them might even be certain fragments of antigens of the disease-causing organism. Looking at the dose of the antigen, obviously we'll see certain things are going to be dosed with multiple administrations. So sometimes by giving a higher total dose over several administrations can help to provide a better immune response. Thinking kind of the type of vaccine, which again we'll talk more about a little bit later, we'll see that certain ones generate a better immune response. And then looking at the route and site of the administration. So for instance, you'll see something like the hepatitis B vaccine is recommended to be given in the deltoid because you get better absorption into the bloodstream, better generation of an immune response versus the gluteal area. Obviously, there's concerns with hitting nerves in that area, but also you just don't get as good of an absorption unless you're less likely to get a durable kind of response to that vaccine administration. Looking at the host factors as well, so obviously patients in the extremes of age, either very, very young or very, very old, may not be able to mount an appropriate response to the antigen and thus may not be able to generate those antibodies. Also, you have to be concerned with, especially young children, if you have the presence of a maternal antibody. If a child is being exposed to something and there's still maternal antibody floating around, it may neutralize the antigen before the patient has a chance to actually mount their own response to it. Also looking at things like the interval between immunizations, so that you'll see that there are recommended times between getting different vaccines, so it could be weeks to months, and either going too long or too short can influence how well the patient will be able to generate a response to that. And then whether or not they have coexisting disease. So if your immune system is busy fighting off another infection, it's going to be very difficult for your body to have kind of the resources to focus on this antibody or this antigen and generate those antibodies. So looking at the different types of vaccines, we mentioned a few already, but the first one being the live attenuated. So again, this is an antibody or virus that has been cultivated and they've been bred in such a way to disable their virulence. So essentially, you're getting exposed to the antigens without actually getting the disease to go with it. This is probably the best way to elicit an immune response since the type of antibodies you have generated in the amount are going to be fairly similar to if you actually had the illness itself. So this is kind of the ideal situation to get the actual live bacteria or virus that's just been kind of neutered a little bit to make make it less dangerous. We'll see that there's some problems with this, especially if you have immunocompromised patients who may actually manifest issues related to the disease since they can't fight it off effectively. Moving on from there, you can have killed or inactivated vaccines where these are the whole microorganisms. They've either been killed by a chemical reagent or heat. And so these are not actually active, but they still have the antibody or the antigens present. So your body can generate a response to it, but it's not going to be as durable as you would see with the live attenuated. So you typically going to need repeated dosing or repeated exposure to those antigens to generate a good durable antibody response. And then beyond that, you have fractional vaccines. So certainly some can be protein-based. One of the examples being a toxoid, where you can actually generate a response to the toxic compounds from the microorganism. So certainly like tetanus would be a good example of that. You can have that, or you can have like a subunit protein base where it's actually a fragment of the microorganism that's been kind of broken off from the host. Can be used to generate an immune response. And then you can also have a polysaccharide based one where we actually can conjugate some of the outer coating proteins to this polysaccharide base in order to help generate a response. You could have recombinant vaccines, which are basically generated from either E. coli or yeast cells to produce those fractional pieces that we're talking about. And then obviously there's immune sera as well, which can be used from donor blood plasma to give this IgG that's useful for generating an immune response. So again, with the live vaccines, they're typically going to be attenuated or weakened wild virus or bacteria. When they're in the host themselves, they'll be able to replicate, and they must be able to replicate in order to be effective. That way, they have similar volumes of the virus or bacteria as you would see in the actual disease. That immune response is going to resemble that natural infection. So with this one, because you're getting kind of a higher load of the antigen, you're going to see a much more durable response, or that stronger memory, kind of that immune memory, with fewer doses. Um, they have kind of the downside that they're going to be less stable, since it is the kind of the live version of the organism. Um, and then they can also interfere with circulating antibodies. So certainly, if maternal antibodies are still floating around, they can actually end up neutralizing these and making the host response less effective. Now, if you have patients who are it is possible to generate, kind of severe reactions to these, especially if they are immunocompromised. They can actually manifest the actual disease, since they can't really fight off these weakened versions. And then, as I mentioned, with the pregnant women or infants, obviously they may not actually get a whole lot of benefit from that, since either dealing with the kind of a weakened immune system, or just the maternal antibodies floating around for the infants themselves. Some live vaccine examples include things like your measles, mumps, and rubella, varicella and zoster, influenza, rotavirus, and then for the bacterial, you can see the BCG vaccine, which is not administered here in the U.S., and then also oral typhoid. The next ones would be our killed or inactive vaccines. Again, these are not going to be actively replicating or causing disease in the recipient, and so essentially these inactive antigens are going to have pretty minimal interference with already circulating antibodies, and you're going to see larger doses are needed to elicit that kind of immune memory. Typically, you'll see that the immunity is going to be pretty temporary for the most part, so you're going to be requiring several doses, between 3 to 5, and then you get really your most protective response after the second or third dose. This is why it's really important to make sure they get all doses within the series. Otherwise, if they wait too long, they won't be able to really generate that memory response, and so they may need to restart the series altogether. And then this would also be a case where the antibody titers would actually diminish over time, and so boosters may be necessary in order to help kind of reinvigorate that immune memory. Looking here, you can see various varieties of killed and inactive vaccines. So certainly on the whole cell side, you can see in the viral category things like polio, rabies, hepatitis A. Influenza, we used to have a variety that was basically the whole organism that was inactivated, no longer available in the US though, so typically we're using like a live attenuated version. And then on the bacterial side, you have things like pertussis, typhoid, cholera, the plague. And then you'll also see some that are going to be more fractional. So either they're the toxoid, where it's actually the toxic component of the organism, or it's going to be a subunit or a piece of that organism. So certainly subunit ones can include things like hepatitis B, acellular pertussis, HPV, and then also the toxoids you'll see most often, diphtheria and tetanus. The next group is going to be our polysaccharide vaccines. There's kind of two varieties. One's a pure polysaccharide, and then a conjugate polysaccharide. The pure ones just mean that they are this kind of the sugar molecules that are found on the external capsule of these bacteria. And these are going to be T cell independent antigens, and so because of that, they really don't elicit a very good response in children that are less than 2 years of age. They really just can't mount a good response to that type of component. And even then, like repeated doses don't really cause that good booster response in your antibody titers. But some examples include things like your pneumococcal, meningococcal, and salmonella. The conjugate, on the other hand, are proteins that are attached to these polysaccharide conjugates. And these are going to be T cell dependent, which will increase its immunogenicity. So it's going to be able to elicit a better response. This will be effective in kids as young as 2 months of age. Again, that's a kind of period of time where the maternal antibodies have kind of gone away to some degree, and they're going to be able to mount their own response. But certainly your HIB would fall in this category, pneumococcal and meningococcal as well. So there's different varieties. One may be a pure polysaccharide versus one may be a conjugate. They'll have different brand names that are associated with that. Then you can have recombinant vaccines, So an example would be essentially where you would insert viral gene segments into the genes of a yeast. And so you can actually have the yeast producing pure antigen. So things like your hepatitis B vaccine, HPV would fall in this category. And then you can also have a live attenuated recombinant vaccines where like typhoid would fall in this category. It's actually generated kind of a modified salmonella. And then intranasal influenza also falls in this category as well. So looking at the timing and spacing of vaccines, how I can give them and how to make them all effective. As a general rule, all vaccines can be administered at the same time as all other vaccines. So that's kind of the general rule. But some caveats to that. So if I'm giving two or more inactive vaccines, I can give them simultaneously or I can give them at any interval. Doesn't really matter because you won't see any interaction between the immune response to one inactive to another inactive. If I'm giving an inactive and a live vaccine, those can either be administered simultaneously or at any interval, because again, they won't interfere with one another. Now, on the other hand, if I'm giving two or more live vaccines, you can either give them simultaneously, the body's going to generate a pretty good response, or they need to be given at least 4 weeks apart. The reason for that is if I give one live vaccine and my immune system's kind of ramped up to the first one, and then I give the second one within that 4-week period, you're going to see that you don't really generate as good of an immune response because your immune system's kind of busy kind of dealing with the other thing, that it won't generate a good response to the second one. So again, either simultaneously or at least 4 weeks apart. Looking at these multi-dose vaccine series, again, the minimum interval between most vaccine doses that you'll see is probably going to be around 4 weeks. Typically, you'll see 5 to 6 months would be elapsing between the next to the last dose and the last dose for these primary immunizing series. Kind of gives you a chance to kind of generate that memory, and then you give some period of time before that very last dose to really kind of generate that final bit of immunity, kind of that good memory. Now, by increasing the interval between doses, it doesn't necessarily diminish the effectiveness, but it may delay how the response you actually get to it. And then decreasing the interval between doses may actually interfere with how well you generate the antibodies response and kind of interfere with the protection. And so again, delays in immunization don't necessarily necessitate restarting the series or adding doses. That's all within reason. So obviously, if you are a day late or a week late to getting the vaccine, that's not really going to be that big of a concern. Now, if it's been a year or more between doses, you may need to consider restarting. And there's guidelines to kind of dictate all of that. Now, looking at patients who are immunosuppressed, that may reduce the efficacy of live vaccines, and it may actually pose a risk for disseminated infection. So in general, if you have a patient who's, say, getting radiation or chemotherapy, you want to either vaccinate 2 weeks beforehand or 3 months after, because that will make sure that A, they're able to generate a good response to it, and then B, they are not going to get they're not going to actually develop the disease itself due to their immunosuppression. And then looking at the separation of live vaccines and actual antibodies. So again, the antibodies are already going to be the active immunity, but looking at the combinations of that with the live vaccine, that if the live vaccine is going to be given first, wait at least 2 weeks before giving the antibody. And then if given at less than 2 weeks, you want to test for the immunity or repeat the vaccine potentially, because you may not have actually generated a good durable response. And then if you've already given the antibody, you need to wait 3 months or longer for the vaccine. The reason for that is you may still have the antibody circulating around that will interfere with the vaccine and prevent the host from actually mounting their own response. So looking at contraindications and precautions, this table is handy because it kind of gives you an idea of when it's safe to vaccinate and when it's not. So C would be contraindication, V is going to be to vaccinate, and P is going to mean precautions, which means there may be certain circumstances where you do want to vaccinate and certain ones where you don't. So looking at the live vaccines, certainly if you have an anaphylactic allergy to the components, that goes for both live and inactivated vaccines, you don't want to administer it. Either find an alternative or they may not be able to receive the vaccine at all. If they have an active encephalopathy, especially if it's thought to be due to a previous administration of some of these vaccines, you don't want to administer that. Now, if they're pregnant, you don't want to administer the live vaccine. It's going to be contraindicated because it may, due to some degree of a weakened immune system, they may not be able to mount a good response to it. But on the other hand, for an inactivated vaccine, those are okay to give to pregnant patients because you're not really worried about them generating or having that actual disease response. They're immunosuppressed. Inactivated vaccines are okay. Live vaccines, on the other hand, are not going to be. And then looking at severe illness, obviously it's going to be depending on what the issue is, whether it be, kind of the complications of HIV infection or AIDS, different things like that. You'll see when you look at the different vaccine schedules as opposed what the general consensus is, if it's okay to administer or not. And then if you had recent blood products, having these blood products already has antibodies against certain disease states, so you may have some issues with the live vaccines being administered, not generating a good response. But in general, the inactivated vaccines are okay to give. Now, looking at there's lots of components to the vaccines, insofar as different proteins or different products that are used in order to help generate the vaccines themselves. And so because of that, a patient may not actually have an allergy to the actual disease component or whatever the actual vaccine component is that's generating the immunity. Could be due to some of the other adjuvants that are included with that. So, this is not meant to memorize this list, but certainly just some examples to where if a patient has an egg allergy, well, they probably shouldn't receive some of the flu vaccines or yellow fever. They have a latex allergy. Latex is involved in the manufacturing of a lot of these vaccines, and so you wouldn't want to, if they have a very severe latex allergy, you may need to avoid all vaccines. So just an idea that, look at your contraindications and look at your patient's allergy list prior to administering these to make sure there's no contraindications. So then moving on, we'll look at the childhood immunization series. So looking at the list of recommended immunizations, and again, I'm not going to make you guys memorize this entire list or the schedule for that matter. That would be, I think, counted as cruel and unusual punishment. But just an example of the different vaccines that are recommended for childhood. So things like the rotavirus, obviously diphtheria, tetanus, pertussis fall on this list. Pneumococcal, IPV, all these different things are all recommended at some point in the kid's life in order to help reduce the incidence of all these disease states. Now, when looking at the recommendations for vaccines, you'll see that the CDC posts new schedules for both the kids and adults every year in January. So as you can tell, this is why I don't ask you guys to memorize this list, because it would be darn near impossible. So you'll find these in a lot of offices already posted up, so it's really quick. You just kind of look to see, okay, well, if the kid's coming in for X, Y, and Z visit, say their 2-month visit, what vaccines are they going to be scheduled for? You kind of look it up. And so and as much as possible, try to administer as many vaccines together at the same time as possible. So that way it's kind of a little bit more convenient for the patient, and try to, especially when you use combination products, have multiple vaccines contained in one. That's also useful, especially for kids that are, needles obviously can be pretty traumatizing, so try to limit how many sticks they really need to get. So you notice here, this kind of will follow them all the way from birth all the way up through 18 years of age. You can see that some of them are going to be recommended for all children. You'll see that they also have areas for catch-up immunization, to where if you missed one dose, you could potentially do a catch-up dose. And then for certain high-risk groups, you'll see that they'll be recommended for some kids, but not for all. So certainly if you're looking at something like the meningococcal, it's not always going to be recommended early on in life, but will be by the time they get more to middle school type age. Again, here's another chart that you'll see in the CDC recommendations. This is an example of the catch-up schedule for patients. We can see where if they miss a a dose, you look to see the minimum amount of time between doses, so that way they can generate a good immune response. So looking at something like the hepatitis B, you see that from dose 1 to dose 2 should have at least 4 weeks, dose 2 to 3 at least 8 weeks, and they need to be at least 16 weeks after the first dose. Again, so it kind of gives you some guidance. It seems complicated, but if you're looking at individual ones, you can kind of see where you're at and how you should how you should proceed for immunizing that patient. Again, it's important not to go too early because they might not actually generate a good immune response to that. And then looking at the adult immunization schedule, we see that for all adults, they really should be up to date on their tetanus, MMR, varicella, and influenza. Looking at patients who are 50 years or older, certainly looking at getting influenza, IM only, not really going to be good candidates for intranasal necessarily. And then older patients, especially over 65 years of age, pneumococcal is going to be recommended. They've probably gotten it earlier in life, but this is to help as they get older and more susceptible to infection, make sure that they can protect against the pneumococcal infections. And then you'll see that there's going to be a lot of immunizations that are going to be for specific needs. So things like hepatitis A, vaccines for international travel, Lyme disease, and all kinds of other things, which I'll talk about in just a minute. So you can see the adult immunization schedule here. Again, this is the 2016 recommendations, kind of following them all the way from 19 up through greater than 65 years of age. So obviously influenza is recommended 1 dose annually, since we'll talk some about some of the specifics on the influenza, but again, because of the changing formulations, you'll see that they are recommended annually. Look at things like your Tdap. Again, that's going to be useful as a booster dose, because again, that's going to be it's not a live vaccine that you're giving when you're giving Tdap or TD, but that's going to be recommended as a booster dose. At least get the Tdap once, because that will include the acellular pertussis component, and then later on you can use TD boosters every 10 years or so. So TD standing for the tetanus, and then also diphtheria immunizations. And then obviously looking at down at the purple section, you see more things that are recommended based on disease states. So looking at meningococcal B, or looking at Haemophilus, certainly pneumococcal, these are all going to be recommended at various times based on disease states. So looking at patients who are pregnant, have HIV, diabetes, asplenia, all these different things are going to be important for specific vaccines. So certainly, like if you have asplenia, you're going to be more prone to pneumococcal infections. So they really recommend getting the pneumococcal vaccine, different things like that. So, and obviously healthcare personnel are going to have their own set of vaccines that are recommended based on their exposures in everyday work. So here's an example of those that are going to be based different medical conditions. So if you look at the top here, you can see where different disease states are there. So certainly if you have HIV infection, based on their CD4 count, obviously if you lower the CD4 count, the more prone they are to different types of infections, chronic liver disease, things like that. So you can see some that are kind of recommended regardless. So certainly like the influenza, the Tdap. You can see with pregnancy, they recommend Tdap each pregnancy, just due to the pertussis risk. And then looking at things like your HPV, things like that. So again, it's all going to be recommended based on the disease state of the patient. So really kind of do your history, find out what special immunocompromisations they may have, and figure out what vaccines they're going to be requiring based on that. Now you will notice that some disease states will have contraindications to some of these vaccines due to the fact that it may actually cause disease. So things like your Zoster or MMR are going to be recommended to be contraindicated for severe immunocompromisation. So especially if you have really decreased CD4 cell count, less than 200, or other immunocompromising conditions. So just keep those in mind. Obviously, don't memorize this whole list, but just be aware that there are differences here, and that each patient needs to be assessed individually based on their disease states and their history. So I've mentioned a lot about the immunocompromised conditions, but what exactly would be considered immunocompromised patients? So certainly if they have any kind of congenital immunodeficiency, so like say a primary IgG deficiency, things like leukemia or generalized malignancies would be in this category. And then also they're receiving chemotherapy, so certainly things like alkylating agents or radiation, antimetabolites, but also patients who are receiving high-dose corticosteroids would also be considered in this category as well. Now, certainly things like, steroids given topically, if you have a multi-dose inhaler, intra-articular injections, things where you're not getting a lot of systemic absorption of the corticosteroids, or short courses, not really going to be considered to be immunosuppressive. So just because you have an asthma exacerbation and you're on a prednisone dose pack doesn't mean you're considered to be immunocompromised. So just for you guys being healthcare professionals, again, annual flu vaccines are going to be recommended. We'll talk about the different varieties, but those are either trivalent or quadrivalent. You'll see the majority of them are going to be quadrivalent nowadays. And this can include either the inactivated virus or the live attenuated influenza vaccine. So the LAIV stands for the live attenuated, and the IIV is inactivated influenza vaccine. Hepatitis B is also going to be recommended, and so you may actually, depending on where you go to work, you may need serological testing to make sure your titers are high enough. Otherwise, it may give you a booster of the hepatitis B. And then looking at tetanus, diphtheria, and pertussis, you'll see that the TD booster, or the tetanus and diphtheria, is recommended every 10 years after your primary series, or you may need a one-time dose of the Tdap just for the pertussis coverage if you're greater than 65 years of age with direct, or less than 65 years of age with the direct patient contact. Other vaccines that might be recommended for healthcare personnel include varicella, especially if they have no serologic proof of immunity. So one of those ones they might take a titer or look at prior vaccination history, and then if it's not present, may need to redose. Certainly MMR may be recommended if they're born later than 1957 without evidence of immunity or prior vaccination. And then for certain patients who may be microbiologists or working with in meningitis isolates, meningococcal vaccine will be recommended. So sometimes it's related to the kind of conditions you're working in versus just in kind of generalized patient care. So now I just kind of want to go through some of the specific vaccines. I'm not going to go through all of them, but just kind of talk about some of the more interesting ones or ones that have kind of special considerations to them. First one being the human papillomavirus or HPV vaccine. We know it's a small DNA virus, and there's lots of different types that are out there. Over 100 types have been identified. A lot of it's based on the genetic sequence of their outer capsid protein, so that'll kind of give us the different varieties that we may be able to immunize against. And we know that around 60 types or so are going to be important in infecting non-mucosal or cutaneous tissues. So this is where we see things like skin warts on the hands and the feet. So this isn't really the HPV that we're really talking about. The ones that we are concerned with are going to be the mucosal, the ones that affect the mucus or the genital epithelium. So the really high risk ones that we see that are going to be important here are going to be 16, 18, 31, and 45. There are some others, but those are the biggest ones. And then some of the low risk types include things like 6 and 11. So it's estimated that about 6.2 million people are going to be newly infected in the U.S. each year. So it's very, very prevalent. And then they estimate that over 80% of sexually active women have actually acquired HPV by the age of 50. So again, it's one of those things that may be asymptomatic for a good long time. And so a lot of people don't necessarily know that they're infected or that they're spreading it. Infection is also going to be fairly common in men as well. So the big reason why this is such a huge deal is that the high-risk HPV types have been detected in 99% of cervical cancers. Looking at it, you can see that 70% of cervical cancers, and anal cancers as well, are caused by type 16 and 18. So these are going to be really, really important to protect against if possible. And then you also see that 90% of genital warts are caused by type 6 and 11. So even though these don't necessarily cause cervical cancer, we do see that these are very prevalent in these sexually transmitted varieties. So like I said, most are asymptomatic and result in no clinical disease, and so which is why it's so easy for it to spread, because you may not know that you have it or not. But certainly if they do manifest can obviously genital warts are going to be the big thing you're going to see here, and then you can also see this cervical cancer precursors like these neoplasias that can happen. Other types of cancers that can be involved with are kind of, anal, vaginal, vulvar, and some head and neck cancers as well can be seen here. So while this slide's a little blurry, you can still see kind of the insidious nature of the disease. So on the left side here, you see the initial HPV infection, and some patients will clear it, within the year or so, but otherwise it will have potentially a persistent infection with this cervical intraepithelial neoplasia. It's kind of grade 1, so it's kind of the lowest grade. Again, it can be cleared from there, but could advance itself to either stage 2 or 3, CIN up to 1 to 5 years, and then potentially even decades later can lead to cervical cancer. So an infection you may get when you're 18 may lead to cancer several decades later. So this is why it's so important that we can protect against it early. So the first HPV vaccine that we had was Gardasil that was approved back in June of 2006. And so it's a quadrivalent vaccine, meaning it has 4 valences that are able to generate an immune response to the HPV types 6, 11, 16, and 18. And so it's indicated for prevention of HPV-related cancers and also genital warts as well. And so it was originally approved for females aged 9 through 26 years of age. And essentially, you're giving it as a 3-dose series, so you give it at time 0.0, so the first dose, 2, and then 6 months later. And again, you are looking for minimum intervals here, because if you give it too soon, then you may not be able to generate that durable immune memory to the disease state. Now we also have another variety called Cervarix, which is going to protect against HPV type 16 and 18. And in regards to males, males can also receive Gardasil up through age 21. It was not originally marketed for them, but they can receive it since it will protect against type 6 and 11, since those are the most common varieties to cause anal warts. So men can receive Gardasil, but they really wouldn't have any benefit from receiving the Cervarix since they don't have the risk for developing cervical cancer from type 16 and 18. So this vaccine is recommended for females aged 11 to 12. And you can start as early as 9 years of age, but it's really at the clinician's discretion depending on lifestyle and things like that. Really, they should be recommended for females between 13 and 26 years of age if they have not previously been vaccinated. And it should be administered before the onset of sexual activity if possible to help prevent the spread of infection before it begins. And then obviously females who are already sexually active should be vaccinated as well, just in case they haven't caught it yet. Now, the vaccine obviously will not have any effect on existing disease or infection, so if you've already had it, it's not going to be able to protect against that. And certainly, vaccination is okay for females 26 years of age or younger who have, if they have a positive HPV DNA, genital warts, lactating, breastfeeding. Generally, it's going to be fine for all of these patients. So, really few contraindications to receiving it. Now, of course, just because you get the vaccine does not mean there should be a change in cervical cancer screenings. And so 30% of the cervical cancers that are caused by HPV types are not going to be prevented by the vaccine. Again, we can't make a vaccine that's going to cover every single subtype, so it's still important to have your screenings as normal. And so, instances where this would be important, especially if vaccinated females could be subsequently infected with a non-vaccine protected HPV type, or if they were already sexually active to begin with and already had an infection prior to being vaccinated. And so this is why providers really need to educate females on the importance of this, mainly because, they may get a false sense of security from receiving it and say, well, I'm protected, I don't have to worry about it, but really they should still be screened regularly. Moving on, we have the influenza vaccine. So again, we know that transmission can happen through large particle droplets or airborne transmission, and obviously symptoms do not start right at the time of inoculation. So typically need around 1 to 4 days or so for it to incubate, and so adults can still be contagious even before the symptoms really start. Looking at the viral shedding. Obviously, adults can still spread up to 5 days after onset, children maybe up to 10, and then for severely immunocompromised patients, maybe weeks or months since they can't really fight off the infection sufficiently. Now, looking at the peak incidence of influenza, we see that we're still a little bit in the window. We still have some influenza cases happening, and so the time periods are going to change, but mainly you'll see it within the winter months. But depending on the incidence of cases, the CDC may extend how long their recommendations for getting the flu vaccine are going to be. So it's going to be recommended for all persons 6 months and older who do not have a contraindication of the vaccine. So it's so important that we recommend routine vaccinations for patients, all patients, unless they have a true blue contraindication. Now the vaccine is going to be formulated annually, so they try to target it against the most what they forecast to be the most common causative organisms. But again, it's not always going to be 100% perfect, and you may still get a flu infection by a different type than what they have formulated that year's variety against. Originally, there's a trivalent influenza vaccine that contained vaccinations against 2 strains of influenza A and 1 against influenza B. But now we have newer quadrivalent formulations that will target an additional B strain as well. Lots of different brand names for this, including Fluzone, Fluvirin, Fluarix, Fluavel. And again, they're all going to contain the same influenza strains each year, but they're going to be approved for different age groups. So these are going to be your category of inactivated vaccines, so inactivated influenza vaccine, and they're going to be administered via an intramuscular injection. These are going to be recommended for all patients greater than 6 months of age. One of the big differences in administration for children is that children less than 9 years of age getting the flu vaccine for the first time really need to get 2 doses in order to help generate that good immune response. Again, 4 weeks between their doses, and they can be given at the same time as other vaccines as well. Now, there is a variety that is recombinant that's made without egg proteins, so that can be important for patients who have severe allergies to egg proteins. There's also Flu Mist, which is our live attenuated influenza vaccine, which is also a quadrivalent variety that's administered via intranasal administration. And the big thing here is to know your age groups are going to be able to receive it. So again, this is going to be approved for healthy people who are aged 2 to 49 years of age. Again, similar to what we saw before, children 2 to 8 years of age getting the vaccine for the first time really should get 2 doses of it. And here you're going to wait a little bit longer between doses, so around 6 to 10 weeks this time. And again, if not given simultaneously, you really need to space those live vaccines out at least 4 weeks apart. Now, some contraindications to receiving the flu mist would be if they have a severe allergic reaction, including those egg proteins. This is why it's important to monitor for allergic reactions for some period after they get it, usually 20-30 minutes or so, just make sure the patient doesn't have a delayed reaction. And then also a concomitant aspirin use in children and adolescents is not recommended when receiving the flu mist. Other patients who it's not going to be recommended for are going to include pregnant women, immunosuppressed patients, because again, this is a live attenuated vaccine, egg allergies, as we mentioned before, and then patients who are 2 to 4 years of age with asthma or wheezing, and then also they've received antivirals within 48 hours. This would be things like your oseltamivir or Tamiflu. That is commonly used for flu. Obviously, that would interfere with the ability for the body to actually generate a response against it. As far as adverse reactions go, you'll typically see some local reactions, especially at the site of injection. So some pain, swelling, and redness. See, it's pretty common with inactivated vaccines, especially. But for the most part, it'll be mild, self-limited. You can see some more systemic manifestations, so certainly things like fever, malaise, and headache. It's where you often have people complaining about saying, oh, I got the flu vaccine and now I had the flu. Usually it's more related to some of these systemic manifestations of their body mounting that immune response. And then allergic responses are possible. They're pretty rare for the most part, but again, looking at their allergies beforehand, assessing risk is important here. If you do have an adverse event in response to a vaccine being given, they have the Vaccine Adverse Event Reporting System, or VAERS. This is actually a nationwide reporting system put on by the FDA for looking for adverse events that occur after immunizations. And providers are always encouraged to report all the clinically significant adverse effects following administration to any person of age, and there's a toll-free number you can call to report this or report it online. And then there's also the National Vaccine Injury Compensation Program. It's kind of a no-fault system of the Health Resources and Services Administration, the HRSA. And this is for compensating those people who have been injured by childhood vaccines administered in the public or private sector. So not something you'll see used all that too often, but it is available as a national program. And of course, people are so worried about the dangers of the vaccine, so oftentimes you'll see lots of kind of negative marketing about um, vaccines in general and how they can cause all kinds of issues. I like how they put polymyxin B and neomycin as being immunotoxins and neurotoxins, and even potassium chloride is a neurotoxin. Well, everyone's got potassium chloride in their system anyway. So you just be aware that people have a lot of misconceptions about vaccines, and so it's important to make sure that we're educating appropriately on the risk and the benefits of the vaccines. And of course, there's always concerns about risk of autism with vaccines. And so the big thing that it was thought to be related to was a preservative that was mercury-based called thimerosal that's found in these certain vaccines. And so fortunately, there's been lots of studies done to look at the exposure of thimerosal, and the CDC has even come out with a public announcement saying that, hey, there's no issues with thimerosal. It's not related to autism. But certainly, a lot of the manufacturers, in order to help get kind of get out of the way of a lot of that negative marketing, they removed thimerosal and used other preservatives instead. A couple other interesting places where you may see vaccines being used, just kind of mentioned here. So rabies being one of the big ones you may see, especially if you're working in like an emergency department and you have an animal bite that comes in. Rabies is something you're going to be more focusing on the prophylactic side of things than actually ever treating, fortunately. It's an RNA virus that is very, very highly fatal if it actually develops. And so we see that, especially outside of the U.S., that it has the highest fatality rate of any infectious disease. So anywhere between 30 and 70,000 fatalities reported annually. Really only about 3 per year in the U.S. So it's fairly rare. It's really found everywhere except for in Hawaii, where they don't have really many of the animals to spread it there. You see transmission almost always occurs through a bite. Rarely can see it either through aerosolization or transplantation of organs that may have been contaminated, but certainly do good screenings of that to try to prevent that. So mostly through bites. And you see that in most developing countries is that dogs will account for 90% of the rabies spread. Here in the U.S., though, fortunately, most dogs are immunized against it. Most dogs have to have proof of their shots and things like that, so you don't really see it being from dogs so much here in the U.S. But certainly bats, raccoons, skunks, and foxes are going to be very common harbingers of the rabies vaccine or rabies disease. So typically what you end up seeing is that the virus will be inserted peripherally in a wound, and then what it'll actually do is travel up the dorsal root ganglion to the brain. From there, once it's in the CNS, it's able to replicate and go to the heart, skin, and the salivary glands. And so looking at things that will affect the infection risk, you look at things like the inoculum size or how much the saliva is actually being administered, the infecting variant or what type of variety of the virus is there. Looking at how innervated the site is, the more heavily innervated it is, the higher the ability for the rabies to actually travel up that. And then looking at host immunity as well. Certainly people that are going to be more likely to be exposed to rabies should receive the vaccine, and so hopefully they'll already have immunity against the virus. Looking at the manifestations, as we know, it's highly fatal. Usually the big effects we're going to be looking at are going to be more from the CNS side. So there's these encephalitic or furious manifestations, usually pop up in around 80% of patients that develop symptoms. Includes things like aerophobia or hydrophobia, where they're actually kind of scared of water and air. Certainly, if you ever watch videos, it's very kind of interesting to look at how they respond to things like puffs of air in their face. You can also have these paralytic issues that pop up, so quadriparesis, kind of mimics like a Guillain-Barré type syndrome. And you typically see very little cerebral involvement until kind of late course. So what the general course is going to be this kind of incubation, kind of the prodrome, the acute neurologic syndromes, and then eventually coma and death. So again, once you already are starting to manifest symptoms, you're kind of behind the 8 ball for the most part. And again, the incubation time can be pretty long, so anywhere between 1 to 3 months average time. It could be several days to 1 year in some rare instances. Obviously, the closer to the brain the kind of shorter that nerve distance that the virus has to travel, the faster it's going to be able to have its onset. So obviously, a bite to your toe is going to travel a lot slower to the brain than it would be if it was, say, in your neck. Looking at preventative care, so again, most of the time you're going to be dealing with someone coming into the acute care clinic or into an ED who said, "Hey, I got bit by this animal." Big thing to do up front is going to be wound care. So again, a thorough washing with soap and water. If you can use a virucidal agent like povidone iodine, would be important. And then this will, in general, will reduce the likelihood of developing disease by around 90% or so. Certainly, depending on the type of animal or human bite it might have been, antibiotics may be indicated. Usually something with some anaerobic coverage, so like an amoxicillin, clavulanic acid, or is generally like an augmentin is going to be recommended there. And then if your patient's not up to date on their tetanus status, then you should probably update them here. So the thing I wanted to mention here is there's kind of two varieties of treatment for the for post-exposure prophylaxis for rabies. So there's the immune globulin, and there's also going to be the vaccine. So the immune globulin is basically human-derived immune globulin we've kind of spun down and isolated out for the targeted immunity against rabies. And so you'll see the dose here. It's definitely preferred in the U.S. There's kind of two varieties here. They're just prepared different ways. There's also an equine-derived variety, but we don't utilize it here in the U.S. So the big thing here is that because we know that once you develop manifestations of rabies, that you're kind of behind the eight ball, you're kind of very unlikely to save that patient. We like to use immune globulin up front whenever possible, especially if we're really concerned about there being a true infection. So the benefit of using the immune globulin provides immediate neutralization of any virus that's there at the site. So the interesting thing about how you will administer it is that you actually will drop your dose, 20 units per kilogram, and then you inject that and infiltrate it around the bite site itself. So if you're bitten on the hand, you would inject it right around the actual wound itself. And then the rest of it you can administer IM. So that way, because you're assuming that the virus is still there at the bite site, you can try to neutralize it there at the site rather than letting it travel up to the CNS. And then the vaccine would be administered as well. You typically will start to see antibody production around 7 to 10 days after administration, and it does persist for several years. There's a few different varieties, like the human diploid cell vaccine or purified chick embryo cell vaccine. They're going to work pretty much equally effective. And then you'll see that the dosing recommendations is going to depend on whether you're doing pre or post-exposure prophylaxis. But for the most part, you'll be more involved in the post-exposure prophylaxis. And then you never want to administer in the gluteal area, like we kind of mentioned before. The deltoid is going to be preferred here. The vaccine for post-exposure prophylaxis will typically be administered intramuscularly, again in the deltoid, at day 0, 7, and then either 21 or 28 days after the first dose. And then if they've already received pre-exposure prophylaxis, so this would be patients who are more likely to deal with rabies, so certainly people in animal control and things like that, they would be getting a booster at day 0 only. And so essentially you would look at your algorithm and try to decide whether or not you would need to treat with post-exposure prophylaxis. So kind of starting at the top, you look at things like, okay, did an exposure to rabies actually occur? So again, did a animal with fur bite the patient? Nope, you probably don't need post-exposure prophylaxis. Is there an open wound, broken skin, or mucous membrane where they was actually in contact with saliva? Or if you were in contact with the central nervous system tissue of the mammal, nope, you don't need to worry about prophylaxis. And then did the patient have direct contact with a bat such that a bite or scratch cannot be ruled out? So this would be kind of the case where if you ever have a patient that wakes up in their, say in the morning, and they notice that a bat has actually gotten into the room, they can't really say for sure whether or not they're bitten. Those patients would be considered at risk and thus would need post-exposure prophylaxis. So again, then you kind of will delineate it based on the type of animal they're exposed to. So is it a high-risk animal? Is it a bat, raccoon, skunk, those type of things? If the animal's available to test, then you could always quarantine it and then test the animal itself. And then if it's positive, you can start post-exposure prophylaxis. But if not, if you don't know what the animal is, then you go ahead and start prophylaxis anyway. Obviously, if it's a low-risk animal, things like a squirrel, chipmunk, rabbit, don't have to worry about it. And then looking at dogs, cats, or ferrets, if the animal's unavailable, say it was a wild dog or who knows, wild ferret could be out there biting people, you would want to start post-exposure prophylaxis promptly if they're not available. Whereas on the other hand, if you have the animal that's either healthy or available for quarantine, then you may not necessarily need to do that. Certainly, if you hold on to the animal for 10 days and they're still not manifesting symptoms, then you're good to go. Or if the animal has symptoms consistent with rabies, then you need to start the post-exposure prophylaxis and then actually test the animal itself, which unfortunately is a post-mortem test. And then if it's negative, then you can discontinue at that point. And then looking at things like small pocket pets, so guinea pigs, gerbils, hamsters, looking at their risk factors. So again, if they house exclusively indoors, then if yes, then they probably need prophylaxis. The risk for rabies is so low at that point. Going back to the dog and cat thing real quick, if they have papers that say that yes, their rabies vaccines are up to date, then you typically don't need to worry about vaccine at that point. Next up, we have Immuneglobulin, which is going to be IgG derived from pooled donor plasma. And because it's coming from a donor pool, you're going to see it has IgG that's going to be effective against lots of different pathogens. Very long half-life, so you typically don't need to administer it very frequently. And it's used for lots of different conditions. The ones that it's labeled for include things like primary immune deficiency, where patients are not generating their own IgG, ITP being another big one, and Kawasaki's. Of course, there's lots and lots of off-label uses for it. I've seen it used for, lupus nephritis has been resistant to corticosteroids. I've seen it used for rejection of organs and lots of different things. Obviously, some things have more evidence for it than not. The big problem is it's very, very expensive, and it's also is not without adverse effects, and so some patients can have a reaction to it. So especially rate-related issues where you can have nausea, vomiting, chills associated with it, lots of headaches. So it's really important that you start the dose very slow, maybe just a few mLs an hour, and then gradually titrate it based on how the patient responds to the dose. Again, very expensive, about $200 a gram. So this is why we try to prevent it being used just willy-nilly for any type of disease state. Really needs to be for something that has at least some evidence behind its use. And then when looking at, there's lots of different brands that are available. You'll see that some patients will have better reactions to one versus another. Just because you're allergic to one variety, say like Privigen, doesn't mean you can't get something like GammaGuard the next time. Just be aware there's lots of varieties that are out there. One of the last things we'll talk about is this Rho-D immune globulin. Lots of brand names like Winro, Hyper-Rho, and Rhogam. This is going to be in particular for patients who are Rho-D negative and may be exposed to Rho-D positive erythrocytes. Again, this is mainly going to be in pregnant mothers who are Rho-D negative that may have, the father may be Rho-D positive. So again, this can be a big cause for hemolytic disease of the newborn. If the mother is Rho-D negative and she mounts a immune response against that. So by giving the immune globulin, it helps to reduce the antibody formation by the mom. And so the big thing here is you need to know what the mom's Rho-D status is. So if they're Rho-D positive or they have anti-Rho antibodies, and this is not going to be a drug you want to administer, since it really is not going to be clinically useful at all. So if there are any questions, I'll certainly be happy to take those. Otherwise, I'll see you guys on Monday.